Hi guys, something interesting I saw on last time I was at work. So often when you make recommendations to patients, you don't actually get to see the outcome a lot. Like you just tell them to speak to the doctor, like unless you can follow it up for them, you generally don't always know. But in this case, I did see one which I talked to the patient almost a year ago now, and I managed to see the follow-up thing, and that was to do with a drug dose and how it was incorrect. So I thought this would be a good learning opportunity for some of you guys. Okay, so quick disclaimer, not medical advice, no promises for any exam results or anything like that. Alright, so this happened way back in December of 2020. So if you're watching this sometime later, currently it is October 2021, so almost a year ago. So a mum has come in, has wanted this script filled for Seretide, also requested Ventolin for her son. The son was 14 at the time, 14 years old. So do we know what the dose of Seretide is meant to be? Now, MDIs, they are meant to be 2BD. So for children and adults, for children over the age of 12, it should be 2 inhalations twice a day. Now, why is this? There's the answer, just straight from EMIMS. They have not evaluated 1BD dosage for MDIs, basically. So I noticed this, that the dose was a bit under. Basically, well, there's a really quick and easy way to work that, to try to get a rough gauge of dosages. So one being, you look at the quantity. So the quick tip, in general, if a medicine needs to be taken regularly, so as in they're taking it monthly, then the quantity generally should also last for a month. This isn't true for everything, but it is quite true for most medicines. So in this instant, the Seretide had a quantity of 120 puffs, meaning you should be doing 4 puffs in a day. So that's basically 2 twice a day is 4 puffs. 4 divided into 120 is 30, so that's a 1 month supply. So another really obvious example of this is Spiriva. So Spiriva comes in 2 different forms, the Respimat and the HandiHaler. So in the Respimat, you get 60 puffs from it, meaning the total daily dose is 2 puffs once a day. And in the HandiHaler, you get 30 capsules, meaning the total daily dose is 1 once a day. So please make sure you know this. A lot of prescribers still write 1 once a day for the Respimat. So this is one thing that commonly occurs in practice. So yeah, quick little tip. In general, if it's meant to be a monthly medicine, it should last for a month. So back to here. So I noticed it was wrong. And just take a looking at the intervals that they're getting the Ventolin or Asmol, so the salbutamol. You can see that it's not really being properly controlled. So I've blocked some stuff out for privacy reasons, obviously. But you can see from way back in the 6th, so the middle of the year, all the way up to December, they've picked up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 different Ventolins, Asmols, or salbutamols, whatever you want to call them. So obviously something's not right in terms of their control of the Seretide. So it could be related to the fact that they're essentially being underdosed, so they're doing 1 twice a day as opposed to 2 twice a day. Now, this was a Sunday, so I could not actually speak to the prescriber. That's what I usually would have done. So I spoke to the mum, and this was the note that I left. So I basically said, so you should be recording these things whenever whenever you're doing these types of things. You should be making notes when you speak to patients, especially important things. So the patients spoke to their mum about the frequency of the Ventolin. She said the doctor. So the doctor actually told her to take 2 puffs of the Ventolin in the morning and at night before he takes the Seretide dose, and he does this every day. So I said it's possible to build tolerance to Ventolin if he uses it this frequently, and I also mentioned that the usual dose of the Seretide should be 2 twice a day as opposed to once a day. And the mum was really good. She was really appreciative that I did tell her this, and she did actually say she had been quite concerned with the amount of Ventolin he has been using. And we'll speak to the doctor soon. So basically, I'd not seen this patient again until recently, until October. So I never even really realized what happened to this patient. I kind of just forgot what happened. And then, so recently this patient came back, and then I did actually get a chance to see their dispensing history. So it was like this. They came back in February. I didn't do this, so I didn't see this patient history until October. And you can now see here that they've increased the dose of serotype, so now it's 250/25, and they're now taking the correct dose, so 2 puffs BD. You can't see it because I've de-identified them, but they actually changed doctors as well. So they're no longer seeing the first doctor that recommended to use that Ventolin at that such high frequency. Now, a lot of people don't know this. I'm not sure if I was even taught this in uni. So you can build a tolerance to beta-agonists. This is both in short-acting and long-acting one. So here's one study. So yeah, they didn't even realize this was a thing at one time. So in the first bit, it says previous reports suggested that regular use of beta-agonists does not lead to tolerance in their bronchodilator. However, most studies have been conducted in stable asthma, and then so in this study they investigate whether bronchodilator tolerance can be demonstrated during acute bronchoconstriction, so basically similar to an asthma attack. And then their concluding thoughts from the study was significant tolerance to bronchodilator effect of inhaled beta agonists may be demonstrated when tested during acute bronchoconstriction. So another study, so regular salbutamol, so that's your Ventolin asthma, resulted in attenuation, so that's reduced function of the acute response to beta agonists, which was increasingly evident with greater bronchoconstriction. So basically saying you're more likely to get the tightness in the chest the more you use salbutamol. Here was a good study, so they're trying to investigate how you can prevent or recover from bronchoconstrictions or so the next few slides are from that. So basically, how do they overcome it? So there are two main strategies. So one, some people just use high dosages of beta agonists or to use an alternative bronchodilator. So there was a study they did, they tried just using a super high dose of the beta agonist, and they basically concluded that basically increasing the dose of the beta agonist does not necessarily overcome the tolerance, but it's still a thing that they sometimes do. But if you use something like ipratropium instead, so the second study, they did measure the response to the anticholinergic ipratropium, and you don't really build a tolerance to this. It tends to work quick enough to help a lot of asthmatics as well. So that's something that can be potentially done. So obviously it depends on the patient when they have acute asthma. So that's something that may be possible to do if they've built a tolerance to the beta agonist. Obviously none of this is medical advice. So if you liked all this, make sure you study efficiently. So dosages are very important. So I know they are no longer tested in your intern oral exam, but like you can see here, it is extremely important for real life. Memorize medicine, easiest way to learn dosages. Back to that patient history, at least 3 different pharmacists saw that dosage and didn't pick up on it. That was the very first time I saw it and picked up on it. So not meaning to brag or whatever, but they're very important for real life. Also, just because you do not see the follow-up in your advice does not mean that you're making a difference. You do make a difference as a pharmacist and when you're making recommendations. So please make sure that your evidence and your knowledge is as high as possible so you can be making these recommendations to help patients that come in. All right, that's it.